within the framework of the PAHO technical cooperation. And I'm going to explain about this webinar in a moment, and I'm going to pass it over to Dr. Ansel Helmholtz, Director of the Non-Transmissible Communicable Diseases. Thank you very much, Dr. Gonza. Good morning, everybody. It is an honor to welcome you to this initial webinar on the better care for non-communicable diseases, to expand quality services for the communities from a equity perspective. I would like to start by remembering why we talk about non-transmissible diseases. They are the main causes for deaths in the Americas and account for over 6 million deaths in 2021. And I want to, and now that accounts for about 65% of all deaths in our region. About 40% of those deaths happen before the age of 70 years. Beyond the impact on mortality, NCDs affect in a very deep manner the quality of living of families. They create disabilities and have a very high social and economic cost for households as well as for health systems. In view of this reality, in 2023, PAHO launched the initiative for better health care for NCDs to improve primary care, health care for these diseases. This is the entry for care for people who are affected by NCDs, and they provide an opportunity to provide better continued care. It's also a space to move towards better, more equity in health by making quality services closer to the peoples and communities that need them most. This initial series of technical seminars will focus on two cross-cutting axis of this initiative. In the first place, to expand diagnosis and treatment to the care of
El segundo es impulsar el uso de guías clínicas, protocolos y vías de atención basadas en evidencia.
Evidence-based care to ensure quality and continuity in health services. These cross-cutting axes are also linked to the development of staff's abilities in primary health, because thanks to interprofessional, well-trained and committed professionals, it is crucial to improve care. This is the basis of this initiative that includes over 20 courses in Spanish, English, and Portuguese in the public health virtual campus. The innovation is that together with these courses, we are now including live technical seminars that will be available as from the following day on the asynchronic mode, so that those who cannot accompany us in real time can also have access to these seminars. And perhaps most importantly, when we complete the evaluations for each seminar, the participants will get a certificate from the Public Health Virtual Campus from PAHO. This initial seminar has a very special concrete focus. They're based on instruments based on available evidence from the region and the countries, and how their use can improve care of NCDs in the region. We will today become available, acquainted with the regional dashboard, and we will listen to experiences from Salvador and Paraguay, showing that when evidence is used in the practice, results in better services and saved lives. I now invite you to take this opportunity. It's an opportunity for shared experience and practical reflection. We are launching a project that will go through December, and it will allow us to strengthen our capacities and move forward together towards more integrated health services and better quality services with a focus on people. Thank you very much. Thank you very much for your participation. Thank you, Dr. Kennings. Once again, good morning, everybody, for joining us in this initial first webinar on evidence-based tools. We have heard Dr. Hennings from present this technical cooperation tool. This is the first webinar of a number of certifiable technicals, and I'm going to ask my technical staff to show some slides, introduction slides. I'm Ines Monset Garcia, and I'm the senior responsible of the initiative. And as Dr. Hennis just mentioned, it responds to a very high priority initiative in PAHO's technical cooperation towards the collective effort to move forwards to provide better health care given the actual conditions that determine the importance of having an important impact on health and social development. Non-communicable diseases are particularly heart, diabetes, obesity, cancer detection, identification of risk factors and respiratory factors can most benefit from having an impact in prevention of and also in early diagnosis, because given an early diagnosis, we can move forward toward a timely care health. This is the fundamental objective of this initiative, where this event in trajectory is comprised. Very briefly also, let me share with you that in the PAHO's web initiative, we have many resources available. This first seminar is part of these technicals, but there are also another 20 resources in Spanish, Portuguese, and English that cover these issues and indicators, and a dashboard for the initiative to look at each country's condition and the movement towards managing these diseases. And PAHO also provides a portfolio of medications and technologies regarding these NCDs. And this is also part of a wider portfolio of courses, including this initial webinar on evidence-based tools that will continue until December and includes 4 other tools. All these webinars are virtual. A significant innovation is that all those of us who are participating this webinar. There are about 380 people that are joined this webinar live, but also you and other important participants can join this webinar asynchronically. This is a resources that will be launched in the Bauhaus Virtual Campus. The cycle will take several months. We're going to continue with these webinars through the end of these seminars in March 2026. So I invite you to join us, and if you have trouble to join any of the seminars online, you can do that later. And once you have taken a brief test on a key knowledge that is proposed in these webinars, you will be able to get a certification for your participation in these webinars. Also, very quickly, I would like to underscore on the ways in which you can access these webinars. You are now participating on online, but to get a certification, you have to join the virtual classroom, and we're going to include the link to enter the virtual classroom in this in the chat box. And the first thing that you have to do is you have to choose the language of your preference. The materials are available in Spanish, English, and Portuguese. So the first thing is to choose the language and then register for the specific webinar. A third important thing is you have to click on the registration button. So choose the language, register for a specific webinar, and register. And the next slide. This is very friendly, intuitive, and you will see as the webinars proceed. This is only the first webinar, and that's shown in the slide showing the location of the webinar and the information to get it and the reference documents related to the webinar's contents that will be key for you to review, be able to answer successfully the questions of the test that you will be given. The next slide, and to conclude, I want to underscore that these webinars will be recorded and that you will be able to review them subsequently later after you register online, and you can also see them even if you have not been able to attend the live session. If you have any questions or issues, or you can find technical help to access these educational resources. And having said this, we're now going to open the technical session, and for that, we will be accompanied by Dr. Ludwig Reis. He is head of the evidence-based, who will be showing us the evidence-based tools. Good morning, Dr. Jonas Hennes, dear colleagues. Good morning, everybody. Can you please now run the presentation? The idea of this presentation, this will be a very brief presentation, but it'll focus on some conceptual and methodological issues that are being implemented in the region, and some of the outcomes that have been achieved in some countries and throughout the region. Please expand the presentation, put it on presentation mode.
¿Ya están viendo la presentación en este momento?
No sí, pero no en modo presentación. Si pueden poner a modo presentación, por favor. Parece que hay un problema con el modo presentación. Ya, perfecto. La siguiente, por favor. Exacto. Bueno, como estaban comentando, estas son las
As
áreas
I mentioned
estratégicas de la
earlier,
iniciativa y una de las áreas estratégicas de la
one of
iniciativa
the
es esta que tiene el
initiative
título de
strategic
promoción
areas has to do
de una
with
viva y mejor calidad
the
de atención.
effort
Esta
to improve
básicamente se liga
training and
a todas las demás, obviamente con el
for
desarrollo del personal de atención, con la
care.
creación de
This has to
métodos y
do with
tecnologías, porque muchas de estas
training of
normativas
staff and
están intervencionadas
technologies and
en
medication,
sitio
and many of the
y
regulations
asimismo con el resto.
concern these
La siguiente,
recommendations
por favor.
and
Y
in these
esto
strategic
es
areas.
el foco
And
del
this is
tema
the
de la
focus of what we're doing to provide support to the initiative for
Por una
better care
parte,
for
la OPS y
non-communicable
la
diseases.
OMS
On the one hand,
desarrollan
both
recomendaciones, ahora vamos a
WHO and
mencionarlas
WHO
más
have
en
developed
detalle,
some recommendations that we're
y
going to look
estas
into more detail
recomendaciones
later. And these recommendations
pueden ser
are
posteriormente
subsequently
adaptadas
adopted or
por los
adapted
países,
by the various
en algunos
countries.
casos ustedes
And
llaman
in
recomendaciones,
cases where
digamos
there
algunas
are no recommendations or there's some
sugerencias
differences
específicas de alineamiento,
specific
cada
for
país
aligning them.
puede
Each country
crear
can
unas
subsequently
guías
prepare their own
protocolos de atención
guidelines and care
específicas.
protocols or clinical
Y para hacer
pathways.
eso,
And
entonces,
to
parte del
do
trabajo de nosotros,
that,
vamos
as part of our work, we
a
will
identificar temas de
uh,
salud prioritaria
support
que
identification of a
necesiten
priority health
utilizar
issues
evidencia
and
para
subsequently
recomendar
use evidence
recomendaciones,
to prepare
apoyar los
recommendations
esfuerzos de implementación
and
y
support
comunicación,
implementation and
hacer
communication
evaluaciones y luego,
efforts,
obviamente, la
conduct
evaluación
evaluations, and
corresponde
subsequently
a
provide
enfocado
sustainability to national
gobierno país.
guidelines
Como tal,
for
otros aspectos adicionales.
NTDs as well as other additional
Para esto
issues.
contamos con
To do
varias
that, we
herramientas.
have several
Lo primero
tools.
que
The
queríamos
first
es
that we wanted to look at is that
muy frecuentemente vemos que
very
existen
often we realize that there
diferencias en
are
el uso de los
differences in the use of the
términos que se usan
terms, the different terms that are used
y esto es
indistinctly.
básicamente para
And
nosotros
this is a
guía de
key
práctica clínica
because for us,
o
a
ruta o una directriz.
clinical
Es un
pathway
conjunto de
or
recomendaciones
directive
que han sido
is a number of
establecidos
recommendations that
históricamente
have
por
been
el
developed
desarrollo de
systematically
decisiones
to support decision
individual
making
o
individually
organizacional.
or
Y
organizationally
estas
for
normalmente
organizations. And
tienen
they
como base revisiones
typically
periódicas
have
que no se
as
suelen
a
medir
support
de
systematic
eficacia y seguridad,
reviews,
sino que también
not
buscan
only on efficacy and
eficiencia
safety, but
con
also look
costos,
for
con equidad, con
reviewing
aceptabilidad, con
evidence on
sostenibilidad y otros
cost,
aspectos que como tal que se
feasibility,
incorporan. Ahora les vamos a
and
hablar más en detalle.
other
Pero ellos
aspects that
además
we'll be reviewing in
incorporan
more detail
el
later,
desarrollo de los
but
grupos de
also in
interés que
developing
serían
them, the groups that develop
mujeres
will
o que
not
su órgano
have
evaluado se haya
conflicts
identificado
of
como
interest,
resistente
or
o que
that
sean
if
resistentes.
those are
Entonces son
identified, they are
aspectos
properly
clave de una guía
managed.
de práctica
Those
clínica
are key
basadas en evidencia que tienen un
aspects
proceso.
of
Los protocolos que se ven
evidence-based
son
uh,
lineamientos ya de
clinical
actuación que
pathways.
detallan la
The
secuencia
care
necesaria
protocols are
para
guidelines
ciertas
to
patologías o
proceed
condiciones específicas
that detail the sequence of activity to
o
follow a
acciones.
certain pathology or
Y
specific
esto
conditions
usualmente ya se
or
basa
interventions or
en
public
estrategias
health
médicas
interventions. And these are
basadas en evidencia
recommendations
que ya
that
cómo
are
se implementan en un
evidence-based,
país y
how
quién son implementadas
how
en
they
ese
are
país.
implemented in the
Ya más
country, by whom,
específicos
and
para mejorar
more
eficiencia
specific
y equidad.
details in
Entonces,
preparing these
muchas veces vemos
care guidelines.
documentos
Oftentimes,
nacionales
we see there are
un poco
national documents in the
heterogéneos porque
countries
tienen las
that look
recomendaciones
like guidelines because they include recommendations. They also include
pero lo que es más
care
importante es
protocols. But
que
what's
sean
most important is that
balanceados.
such
Creo que
recommendations.
se fue la presentación.
I think I cannot see the presentation
Hayan
of the screen.
sido
They have
desarrollados
been
y
prepared
ya
based
posteriormente,
on
voy a
evidence,
poner ya en
and
pantalla, por favor, y
later
ya posteriormente
uh,
las guías clínicas ya son
the
específicamente
clinical
hacia
guidelines are
implementación
the
de representación
implementation
y
tools
manejo de
that
patologías. Es ya
graphically show how those pathologies are implemented, and
ya
such they
para
are
tener un
a
paciente
resource
saber
for
exactamente qué es lo que se está
to
haciendo.
see easily see what are the recommendations in the
Siguiente, por favor.
protocols and the care
Estos
protocols.
son algunos ejemplos
These are some examples. This is a directive for pharmacological treatment of high blood pressure in adults. This is an WHO guidelines that includes specific recommendations. Then we also have the care protocols that specifically show how the guideline will be put into practice, and this is clinical guideline for hearts from hearts that includes several recommendations and the ways that a care will be turned into a protocol. I wanted to mention that WHO and BAHO have a large number of recommendations, and about 4,000 of them that are all evidence-based and for different issues, including maternal health, NCDs, transmissible diseases, communicable diseases, and each of them, and many other issues, and all of them have been included in this database that's called BigRec, which is a catalog, for instance, in non-communicable diseases, and for each of those NCDs, it includes the specific pathologies and specific diseases, and whether these are diagnosis or intervention recommendations. This is available in Spanish, Portuguese, and English, and it is being currently updated on a regular basis, once every 1 or 2 months, and sometimes the translations, because these are official translations into Portuguese, French, or English, can take a little bit longer, but they are permanently being done, and we're constantly including more information so that you can find all this information in Big Red. They include all the recommendations that we have included with evidence, based on evidence provided by the initiative, as well as other recommendations. And how do we support countries, ones that we have all these recommendations, or there are other agencies, like, for instance, Ministry of Health of Chile, or any ministry across the region that already have a guideline that other countries would like to use to adapt them to their own conditions? What is the process that we engage in? It starts with a prioritization of the specific issues that a given country wants to address, and whether high blood pressure, diabetes, diabetes type 1, or high blood pressure diseases. So based on that prioritization, we determined whether there is a recent guideline, whether it's been updated recently, or if it is already, and whether it's updated and it's good quality. That's the first thing that we look at. We also try to identify whether there is evidence that may have changed those recommendations. So we have a guideline that has a systematic reviews with all the guidelines that are priority for a given condition in the country. So we set up an expert team in the country to determine that there is no conflicts of interest, and we provide the evidence. And we also look, more importantly, to look for local evidence that can be a prevalence incidence in the various countries' plans and strategies, and that are included in the initial METS listings at the cost of certain interventions and technologies. And this is particularly important for new technologies or high-cost technologies, but that require further detailed attention. And together with this, we provide the evidence to the staff, to the team, and we include the evidence, and then we provide a recommendation, and those recommendations, proposed recommendations, are adapted, and subsequently we prepare an implementation plan of these recommendations using what we call the gray framework that allows to address the various issues, including feasibility, cost, and equity issues. And this is a methodology that we have included for fast deployment. We have prepared guidelines in 3 to 4 months through this process, and most importantly, we are doing this on a collaborative basis among countries. For instance, cervix cancer prevention guidelines that was prepared in a little bit over 1 year by 4 or 5 countries using the evidence that was provided by what the other countries were doing, and that reduces at times and improves efficiency by using what other countries have already been doing. These are only very quickly, these are some courses, online courses for the systematic periodical reviews and how to prepare guidelines that are evidence-based, and these are the systematic reviews of the literature that are also available in several languages. These are just a couple of examples from the region. We're trying to foster cooperation among the various regions, countries, based on the local evidence that usually takes a bit longer to identify, but they can also be at the sub-region level, and we aim at sharing these resources for other countries to use them very quickly. So, for instance, if we start with the World Health Organization high blood pressure guidelines, so we prepared that initially in Salvador, but then other countries followed the same path. For instance, Mexico prepared some guidelines for cost effectiveness of cervix cancer, and subsequently other countries can focus on preparing their own clinical pathways, which we think that based on these accepted recommendations by various actors, they can focus on specifically how to implement them. This is an example of from our colleagues in El Salvador. You may realize that they have many guidelines that they have prepared in the last few years for many non-communicable diseases, NCDs. And finally, this is a dashboard that we have prepared. As you can see, these initiatives are basically focused on evaluation and monitoring underway. What we did is based on these 8 diseases or conditions that Jonas mentioned initially: diabetes, renal diseases, cardiovascular diseases, etc. We looked for each of the guidelines or care protocols for each of these in each of these countries, and we started by identifying them to determine whether the information was available. If you are aware of any national guidelines available from the Ministry of Health or other national government agencies that is missing here, please let us know, but to include them. But this gives us an overall view of what is available throughout the region and what is missing. And the second decision that we made was that we started to look at almost 250 recommendations for these pathologies, and based on those recommendations, we looked at each of the recommendations in each country and what was the alignment with the evidence-based recommendations included in the World Health Organization's package or some other development standard that we had supported in the region. And as you may see, the green highlights what the countries do have guidelines and how well aligned those are with the organization's developments. The gray boxes show that there's no recommendations or that some particular recommendations have not been developed. And the yellow boxes show partial alignment, and the red highlights show that the recommendations are slightly or very different from our recommendations, so that you may realize that there is much agreement and that where there are more or less recommendations where we should be focusing our collaborative efforts to develop recommendations for those countries. And also we may have to examine what are the alignment differences and what are the reasons, and where there are opportunities for improvement, or there are simply ways in which they approach the various populations or action plans. But this gives you a very specific view of what's happening. And in this table is also available in the links presented by Jonas.
Se requiere institucionalizar la evidencia.
Precisamos institucionalizar.
Creo que hubo un problema ahí con no sé, con el canal. Hay una gran cantidad de recomendaciones disponibles para que sean contextualizadas por los países, y la OPS ofrece cooperación técnica a este ecosistema para que los países sean más rápidamente puedan ir incorporando esto para la iniciativa. Con esto concluyo, y disculpas que me tomé un poco más de tiempo de lo que estaba previsto. Gracias.
Muchísimas gracias, Ludovic. Yo creo que queda muy claro la riqueza de recursos que disponemos a nivel regional y la oportunidad que supone compartirlos, ¿no? Porque el esfuerzo en desarrollar estas herramientas que son claves para acelerar la mejora de la atención es importante. Por lo tanto, precisamente buscar alianzas y construir colectivamente y compartir recursos creo que es clave, y es uno de nuestros objetivos facilitarlo para disponer de estas herramientas rigurosas. Y vamos a entrar ahora en la siguiente presentación, particularmente interesante porque hace ese ejercicio de trasladar lo que es la guía, la recomendación, a la vía clínica, ¿no? Y esto lo tenemos, pues, el modelo de HEARTS en la región de las Américas, con implementación en varios países con un nivel de éxito importante, una intervención multicomponente centrada en la atención primaria, cuyo centro es la vía clínica. Y para ello contamos con el acompañamiento de un miembro del equipo HEARTS de las Américas, el doctor Andrés Rosende, que nos va a compartir precisamente esa perspectiva regional en el modelo HEARTS y la vía clínica de HEARTS. Adelante.
Muchas gracias, Jonás. Saludo a todos los colegas que están participando actualmente del webinar. Si me pueden confirmar que la presentación se vea correctamente en modo presentación, les agradezco.
Sí se ve.
Muy bien, pues allí vamos. Bien, voy a retomar un poco las palabras del doctor Genis para reforzar que las enfermedades cardiovasculares y cerebrovasculares, podemos incluir también las enfermedades renales, es decir, todas las enfermedades que tienen como nexo común la aterosclerosis, la enfermedad de la pared vascular, son la principal causa de muerte y carga de enfermedad a nivel mundial. Y esa enfermedad se produce por un montón de factores de riesgo que la mayoría de ustedes conoce muy bien, pero el peso relativo de cada uno de ellos es diferente y tiene que ver fundamentalmente con la prevalencia que cada una de estas condiciones tiene en la población adulta. Como pueden ver en este gráfico, el peso de la hipertensión como factor de riesgo para mortalidad de causa cardiovascular supera mucho al resto de los factores de riesgo. Lo que quiere decir es que debemos tener un abordaje integral, pero la puerta de entrada más ventajosa para alcanzar estas poblaciones es la hipertensión arterial y por eso Hertz utiliza la hipertensión arterial como puerta de entrada. Porque hay una urgencia en torno a las enfermedades cardiovasculares. ¿Cuál es esa urgencia? Que la tendencia descendente de la mortalidad observada en las últimas 3 décadas se está enlenteciendo. Y si separamos esta tendencia que lleva 30 años, como ustedes podrán ver en este gráfico, en lo que sucedió en la última década, podemos ver que una gran proporción de los países que antes se encontraban en el lado azul del cuadro, es decir, venía año a año reduciendo cada vez más
graph, that is, that cardiovascular disease fatalities were following. This was a significant number of countries have now moved to the other half of this graph, and there, in those countries, deaths from cardiovascular reasons has started to increase significantly. We take into account the 10 main causes for mortality and disabilities: cardiovascular or cerebrovascular, renal, and diabetes mortalities. All these things that are connected to high blood pressure and arteriosclerotic vascular diseases are creating their greatest load. And as the graph on the bottom right shows, the current trajectory of these trends are far from reaching the goals set for in the Sustainable Development Goals for 2030. There is urgency, but this is also a good thing that we have an opportunity. If we look at the mortality figures for the countries and the regions for the last 30 years, and if we add to that the proportion of controlled high blood pressure patients in the region, we find a very strong correlation and a reverse correlation. What that means is that for every percent point that we can increase high blood pressure control among the population, we can expect an impact of about 3% in mortality due to heart ischemic conditions, fatalities, and about 3% also of falls in deaths from cerebral
pero a la vez que es bastante conservadora, que está relacionada con
cardiovascular diseases. So it is important that we realize that we have to diagnose and provide a coverage for at least 80% of these patients have been identified as such, and to control and treat 80% of these. This would mean that moving from 30% of population cardiovascular control to over 50%. Obviously, this may sound very conservative because that would mean that about 50% of the patients are not septic controlled, but the increase would be so significant that we could save over 400,000 deaths, premature deaths, early deaths from these diseases and conditions. And if we can expect from 5 to 7 cardiovascular, non-fatal cardiovascular diseases where the patient gets sick but does not die, thanks to this initiative, we could prevent about 3 million non-fatal events. The difference, the results among countries are very dissimilar, and we can see the cascade of high blood pressure disease. On the red side, the dark red, we have the people who don't know their that have high blood pressures. The light red are the ones that know their condition but do not get any treatment. And so once these patients are diagnosed, access to treatment is very good, but the quality of that treatment results in about about half of the patients that have been diagnosed and treated will not reach control. Those are the ones that are in the light green bar. The objective is that the dark green bar, that's the patients that are identified, treated, and controlled, should be as long as possible. So as you can see, we can interpret this as a subdiagnosis of as a gap to healthcare systems, and that's where we have to work. And the bad control as the quality gap in the health care provided by these services. So HART has this health system approach because of the health system operates as is shown in this slide. It is impossible for hypertension control to improve if we only focus on specialists, doctors. So that's why it's so important, as I mentioned, to provide primary health care as the main territory where these actions can be implemented. And Hearts in the Americans is the World Health Organization's flag program in the Americans for the comprehensive prevention of cardiovascular heart diseases that are very different from the traditional approach, and they are leading to a change in attitude in most regional countries, as we will see later with the El Salvador example. And going back to what Ludovic just mentioned about the importance of evidence-based tools, HARTS has fostered the immersion of a clinical pathway for comprehensive management of cardiovascular conditions. This guideline summarizes in one single page the protocols to care, high blood pressure, the evaluation stratification of cardiovascular risk, and the treatment of concomitant parallel conditions like lipids in the risk assessment or the administration of aspirin for patients that have already had a cardiovascular accident, and a protocol, standardized protocols that includes pharmacological and non-pharmacological innovations in a very straightforward and specific ways, defining the medicines and specific doses, the intervals for intensifying specific therapies to reduce clinical inertia and inappropriate inviolability in practice. At the foundation of clinical pathways, we find other evidence-based protocols, and on the World Health Organization's guidelines for following patients that have already reached control of their hypertension condition, and as well as other recommendations relating to the adherence or the prescriptions for prolonged periods. And finally, in this cross-cutting line, we include both communicable and non-communicable diseases to foster vaccination among adult populations. We know there are huge gaps for pneumococcal and influenza, not so very much for COVID because of the pandemic, but also in the understanding that vaccination strategies are understood as a reinforcement of cardiovascular prevention, because these patients die at the end of the day from cardiovascular complications, and the influence of these types of vaccinations are very important in reducing such accidents. This clinical pathway has been particularly successful and has adapted and adopted 28 countries in the Americas, and we will later take a look at the example of El Salvador. And to go back to what Ludovic said, there are these clinical practice guidelines. Why do we need these clinical pathways guidelines? Because if we have the evidence and the protocols, because each of them has its own participation of place in the way to improve quality of care. Clinical pathways are critical because the amount of evidence is really overwhelming, and to separate the grain from the chaff, it is we will realize where the benefits and risks are acceptable. So the clinical pathways, having a high quality clinical pathways that follow a standardized methodology like the great methodology and that issue recommendations on that basis is the conceptual basis for supporting all the other guides. And why do we need? Because the clinical pathways are sort of a vertical and exhaustive, like for instance, a hypertension, high blood pressure guidelines includes issues that go from diagnosis to the treatment of a secondary hypertension, which are less prevalent. And they are also very extensive and use a very academic and scientific language. Protocols standardize those evidence-based recommendations, but they look at part of the problem. They have a vertical approach. The advantage of a clinical pathways is that they take standardized protocols that are evidence-based included in the clinical pathways, and they include them into the health system from a programmatic rationale that will include several protocols on the same page that are supported by various clinical pathway guidelines, not only for prevention, but also primary preventions, immunizations, and secondary preventions, diabetes, and more. However, although the clinical guidelines have adopted a very wide scope, still the question is how to provide effective
La iniciativa,
response to
perdón,
multiple
¿se me mete la traducción?
morbidity.
Hola, ok. Bueno, ¿cómo dar una respuesta
So,
efectiva a la
how to provide effective
Perdón,
response?
estoy escuchando la traducción de inglés en el canal principal. No sé qué habrá pasado. Bueno, entonces, aquí la iniciativa Mejor Atención para las Enfermedades No Transmisibles es donde entra en juego
NCDs, we include integration of hearts with other conditions that are available, present in other patients, like a cluster of renal, inflammatory, cardio, etc. conditions that also includes the approach from those health services to conditions that typically have a more kind of a regulatory approaches like obesity or tobacco consumption. So we have
unidad que dirige Ludovic de Ciencia y Conocimiento para el Impacto, en fortalecer la vía clínica con la mejor
we are looking for strengthening clinical pathways with the best available evidence. This is a three-step process that has chosen three candidate interventions, and we have asked the Ministry of Health to determine their barriers to identification so that this can become a reality of a primary health care, and through a regular review of evidence and building a consensus around the interventions that will eventually be included. The publications from each of these stages are available. They are open to the public, to anybody who will want to check them. And there are also two other initiatives that we are carrying out, focused on transforming the care model, the Hearts of Pharmacy approach to strengthen the pharmacist and pharmacist care role, and teamwork, where we need more people to be involved from the nursing and community workers members, and following this treatment protocol as determined in the World Health Organization's pharmacological guidelines. I will conclude here. Thanks very much for your attention, and over to you.
Gracias, Andrés, por una exposición, yo creo que muy clarita y muy
Thank you,
amena, ¿no?
Andrés. It was a very interesting
Aparentemente explica un
conference.
proceso que es complejo,
And
tradicional y que está
well,
teniendo éxito. Y para conocer el
this is
éxito
a very complex
que tienen
process,
los
but it is
países,
being
oportunidad de
successful,
conocer
and
experiencias
it
de
gives the
países con sus
countries the
esfuerzos, su contribución.
possibility
Bienvenido, doctor
to
Matías.
know
Bienvenido,
how it is
doctor.
working.
Adelante.
And now we give this, the floor to Mr. Matias Villoro from El Salvador. Good morning. First of all, thank you very much for the opportunity you give us to participate and share our experience in the country. If you could put the presentation here, please. Thank you very much. Here, following the steps of Dr. Ludovic and Dr. Rosende, we have applied these guidelines and we have adapted them and adopted them for the the implementation of hearts in El Salvador. And what I will show you is how we did it. In the first place, I can tell you that the state of implementation of hearts in El Salvador was implemented at national level in the integrated health system. El Salvador has several healthcare providers, including the public health care service and also the Social Security services, and 5% by private insurance companies. And this implementations took place in 4 stages. It started with the first, second, and third level of care by using the same guidelines and protocols. And it has benefited more or less 3.2 million inhabitants. And what was the roadmap for the implementation and the strategy? The first thing was to formalize the implementation of the heart's intervention or strategy, and together with with PAHO and an alliance with the IDB and the World Bank, and because you know that we need financial support, as you know, to do this. So we set up the team for the implementation that was nominated by the Ministry of Health as the highest authority in health issues in our country, and it is part of the Committee of Non-Communicable Diseases, with the participation of all the providers of healthcare, the academia, and civil society organizations. And the next step, from 2021 to 2022, we started to set up the team, and by following a strategy plan that was set up by the implementing team, that includes the National Integrated Health System, and we had to do a series of modifications, such as the incorporation of new technologies in our official lists, such as, for example, digital access routes, the decentralization of this up to the first level of care, and also the elaboration and printing of the guidelines of the clinical guidelines, together with the authority in charge, that is the National Institute of Health. And we followed the instructions and of this institute, and this institute was supported by the developing team with specialists of the National Integrated Healthcare System and a technological team that was provided by PAHO. And as Dr. Ludovic said, these were the ones that were helping us with this process by setting up the clinical guidelines. And we had a panel of experts and representatives of users, that is the patients also. And so we started implementing the right methodology. So after these clinical guidelines and the incorporation of this model in the clinical model of the Ministry of Health and other healthcare providers, so we started then with a training process. This training process was facilitated by PAHO with the steps to follow in order to standardize the clinical guidelines. And we passed this on to the HEARTS team in February 2022, HEARTS team in the country. With these standardized guidelines, we started the training of all staff members in the country. And this has meant a great challenge for us because of the change of paradigms for our health care providers, and including the teams in charge of cardiovascular risk assessment. And since October 2023, we have gone through the stages of technical systems, monitoring and evaluation of the quality of implementation of HEARTS 2.0. And we also took into account all the coagulating factors such as overweight patients, etc. And one of the important issues that we wanted to share with you is to align that we have aligned the strategic framework of health implemented in El Salvador with this strategy. And here, this includes the social development plan, the national health plan, the strategic institutional plan, and others. This was the tool we used. It's a tool recommended by the HEARTS team of PAHO about the traits of an ideal protocol, and we are still assessing all 34 items of this checklist. You can see there is a component about the conditions for optimizing the implementation of the protocol, the clinical guidelines, the anti-hypertensive treatment, and also cardiovascular risk. And this, the application of these tools is being assessed by the teams in charge. And here, this includes in this clinical guidelines, we have the 8 factors that contribute towards heart disease and the 3 components that were already explained by Dr. Vassell. And in component A, we have here the instrument we could use for measuring blood pressure. We have to standardize the tools used, and it's already in our computer clinical histories. And then the protocol of treatment, that is the pharmacological and non-pharmacological treatment, and the continuity of the care provided, the transfer of competences to other team members, and also the follow-up by the community nurses after the intensification of treatment. And here you see how we integrated three tools. We have the clinical, the WHO clinical guidelines, and from WHO and PAHO, and we established this through technical guidelines for the comprehensive treatment of hypertension, diabetes, and chronic kidney disease. And we did the same thing with dialysis, that is renal failure, and these are the results of the clinical treatment of hearts. There is a protocol for standardized treatment, an alignment of the guidelines with the HTA of PAHO and no, of the WHO. And here we have to look at. We also include all the coagulating factors and also the triggering triggers for heart disease, but also how to improve the quality of treatment. And these clinical guidelines have been distributed to all health institutions and are mandatory. And we have gone, these are the points in our implementation starting in 2021, and in 2024 we already have a high degree of implementation. Following. And here we see how we have made our progress in measuring and detecting hypertension in our population. It has been a great improvement, and here we see that 72% of all patients are already under control. We have been able to reduce the premature mortality rates because of these of cardiovascular diseases, and we have reduced the deaths in 14%, and we also have reduced deaths because of diabetes in 24%. And this shows you the results that we have achieved and the roadmap we have followed. Thank you very much, Dr. Villatoro. And this is, of course, the best way to follow all these guidelines and strategies. And we see that you have achieved very good results. And we thank you for sharing the El Salvador experience in order to accelerate, or with the aim to accelerate, the same processes among all of us and provide a better care for our population. The most relevant factors are, of course, cardiovascular diseases, diabetes, and kidney failure, but also some others. We are established technical cooperation with Paraguay also, and Dr. Cynthia Ayala will tell us how the Ministry of Health of El Salvador. Good afternoon. Can you hear me? No, we have some interference here.
Puede ser que tenga dos dispositivos conectados y por eso se escuche eco.
Yes, yes.
Maybe you have two devices connected, and this is why we have an echo.
Listo, ¿se me escucha mejor ahí?
Is it
Creo que
better now?
puede
Yes.
acercar un
Hola,
poco el micrófono mejor.
¿se me escucha mejor?
Ahí
Yes.
mejor.
If
Bueno,
you're
genial.
closer to a
Yo soy la doctora
microphone.
Cintia Ayala
I'm
y
Cynthia
como
Ayala,
ven
Dr.
en la
Cynthia
presentación
Ayala, and
vamos
as
a
you
hablar
see
acerca
here,
de
we'll
nuestra
talk about
experiencia
our experience
en la elaboración y actualización
in
de guías clínicas.
setting up
En la
and
siguiente, por favor.
updating
Nuestro trabajo
guidelines.
comenzó
Our
con
work
el programa
started
nacional contra el tabaquismo
with
que depende
the
de
national
la Dirección
program
Nacional General
against
de Vigilancia de
smoking
Enfermedades No Transmisibles del Ministerio de Salud, que
by the Ministry of
comentó el
Health.
colega de la
And
presentación anterior,
as
también
my colleague
tenemos
in El Salvador said, we also
lo que abarcamos a la población, llegamos al 70% de la población.
have achieved
Sí, lo que tenemos
the level of care
un
for the
trabajo
population of
en base a este
70%.
trabajo.
And
Vemos
well,
este
our
trabajo se
work is
llama
based
la carga pública que implica el tabaquismo en
on,
Paraguay. Y a partir de
well,
este
in
estudio
order
que se hizo en el
on the
2023,
factors
vimos de
that
que el
cause this
13.5% de nuestros pacientes
public
que fallecen
cost
es debido
for
a
our
enfermedades
budget,
relacionadas
and
al
because
tabaquismo. 4.500 muertes al año,
13.7% are related to
43.144 casos de
smoking.
pacientes con
We
enfermedades
have had
pulmonares,
more than
enfermedades cardiovasculares,
43,000 cases of
cánceres. Tenemos el costo económico de lo
patients
que implica el tabaquismo,
with
y eso
EPOC,
representa para la salud
with
pública que no
chronic
está cubierto
obstructive
más de
lung,
800
lung
millones de
disease,
guaraníes, es
cancer,
decir, de
and
dólares.
cardiac diseases and other
La siguiente diapositiva,
diseases
Natalie.
produced by tobacco
También
consumption.
representa un
And it
gasto
also
a nivel de
represents a
empresas
huge
por la
expense for
ausencia laboral,
for
que
the
además de
private
160
industry
millones de dólares, también
because
hay un gasto
of
relacionado con la
absence,
familia
and
que
there
quiere
is
apoyar
also
al paciente con
expenses related
discapacidad. Tenemos
to
pacientes
the
con
families that
enfermedad
have to
pulmonar
care
respiratoria
for the
o algún
patients
tipo de enfermedad
with
relacionada que
lung
llegan a
disease,
necesitar la
chronic
ayuda
lung
de la familia.
disease,
La
or
siguiente, por favor.
cancer.
En esta diapositiva lo que vemos
And
es
in
que al igual que el
on
tabaquismo
this
es una
slide, we
enfermedad
see
transversal a
that
otras enfermedades,
tobacco
tenemos que hay
consumption
21.500
is
pacientes
related
con
also
diabetes
to
y esta
other
diabetes está relacionada
diseases
también
such
al
as
tabaquismo.
diabetes.
Tenemos
And
8.900 pacientes
we have
con
more
EPOC,
than
tenemos
8,000
como
patients
6.000
with
8.640 pacientes con
cardiac
enfermedades
diseases,
cardiovasculares. También tenemos
and we
1.200
have
pacientes con neumonía,
1,300
1.683
patients with
pacientes con
pneumonia, 1,300, more than 1,300
cerebrovasculares,
patients with
765 con cáncer de
no,
pulmón y
vascular
772
accidents
pacientes
affecting the
con
brain,
cánceres de otros tejidos, de otros
755
órganos.
with lung
Siguiente,
cancer,
por
and
favor.
732 with other
Y en
cancer
esta
diseases.
diapositiva lo que
And
tenemos es
here
la
it
cantidad de
shows
muertes relacionadas al
the number
tabaquismo.
of deaths
Como ven, la
related
primera causa
to
de
tobacco
muerte en
consumption. The
enfermedades relacionadas al
first
tabaquismo son las enfermedades
cause of death
las enfermedades
related
cardíacas
to
con
smoking
1.264
are cardiac
casos,
diseases.
luego las enfermedades
With
pulmonares con
and then we have
825
the
casos,
chronic
tenemos el cáncer de
lung
pulmón en tercer lugar,
obstruction,
las enfermedades relacionadas
and
al
we
tabaquismo
have
pasivo,
lung cancer,
otros cánceres
other
también
diseases related
accidentes
to passive
cerebrovasculares, neumonía
smoking,
y diabetes.
and
La siguiente, por
secondary
favor.
smoking, and also
Y
more
con
than
todo eso
500
en mente,
related to
lo que
diabetes.
definimos es
And with
que
this in
necesitamos
mind, we
trabajar
defined
para
that we
desarrollar
came
una
to the
guía
conclusion that we needed
que
to
nos
work
ayude
on
sobre todo a
guidelines that help
estandarizar
us
el
to
manejo de
standardize
las
the
enfermedades
management
pulmonares.
of
¿Para
lung
qué? Para reducir
diseases
las
in
disparidades
order to
y
reduce the
asegurando
disparities
un
and
abordaje
ensure
sobre todo sistemático y transparente en la evaluación de la calidad y la evidencia
systematic
y la solidez
um,
de las
the
recomendaciones.
systematic
Acá,
treatment
bueno,
and
descubrimos de que era muy
also
importante
prevention of these
la
diseases.
implementación
We saw that
de
it was very
prevención
important to
y asimismo
prioritize prevention
definimos de que
more
aparte
than
de una
treatment,
guía
apart from treatment.
clínica
And
para
apart from
las
clinical
enfermedades
guidelines,
pulmonares
for EPOC, we also needed, for obstructive lung disease, we also needed guidelines for cardiac disease and cancer. And so we adapted the guidelines that we had published recently, that were published recently by PAHO related to tobacco consumption. And here, and because we are facing a huge public health problem at world level. According to a study, we discovered that a significant number of physicians do not feel sufficiently trained to provide advice for stopping smoking. And on this slide, we see how Paraguay was evolving or has evolved regarding clinical practice guidelines. We started in 2022 by setting up clinical guidelines for kidney diseases. In 2023, we started with a comprehensive treatment for obesity. In 2025, we launched two guidelines, obstructive cardiac pulmonary disease and also cancer. And here we have the process of updating clinical guidelines and setting up clinical guidelines by following the GRADE system. We have several stages here. The first stage would be the updating also of the training of professionals, setting up a clinical experts panel and review the previous guidelines. And we validated the previous guidelines after reviewing them. This was a methodological work. And then we set up a panel of experts that were going to work on this and the clarification of conflicts of interest. And in this next stage, review of the guidelines, the clinical guidelines, and then we define the scope of each guideline. For us, the goal was to detect patients with chronic pulmonary disease, and these guidelines were directed towards were focused on patients above 18 years of age, and they were distributed at all levels from the primary healthcare clinics up to specialized hospitals. And then we prioritize the questions. Here we have two stages, setting up questions for groups, which was done in a presential manner, and then we prioritized online questions and through an online survey. And then we prioritize the probable results of these guidelines. We establish this individually through an online survey. And then we came to the assessment of the evidence that we found. And then we set up the recommendations and finally the discussion of the guidelines. Here you see the timelines for setting up the guidelines. They started simultaneously or took place simultaneously for obstructive lung disease and for the for stopping tobacco consumption. And then we have, well, here we have the review of the questions, gathering evidence, contextualization, discussing this with a panel of experts, and then launching the guidelines. And these guidelines were then sent out to all users. Here we have the scope and the users of these practical guidelines. The clinical guidelines are focused mainly on the healthcare professionals, including family medicine, then, well, clinical specialists, infectology specialists, pulmonary disease specialists, psychologists, psychiatrists, nurses, physiotherapists, social workers, and members of government entities in order to also enforce them for decision makers. Here we have the two guidelines for the implementation process. We have printed guidelines and also the online versions with the links you see below. On the web pages of the Ministry of Health. For these guidelines to be used and be validated and achieve their results at national level, we need these guidelines to be validated by the ministry, and this was done through a resolution for the epoch for the obstructive lung disease and for heart diseases. And another important thing for setting up the guidelines is how we achieve diagnosis and what to do regarding the difference in our geopolitical structure. Here we see which patients can be affected by these diseases, so that is how to diagnose them, and then what to do and how to treat patients correctly after having established a diagnosis. So apart from diagnosis, the clinical diagnosis, the spirometer diagnosis. Well, we have all the essential, we have distributed all the essential drugs and medication among all the institutions, health institutions in the country. And for the obstructive pulmonary disease, we see here the resolution signed by the Ministry of Health to be able to implement the process. And so there is an algorithm here for the detection of patients, and it also helps to determine at what degree of smoking addiction they were in order to be able to help. And in this sense, regarding medication, we do not have all the necessary medication. We have bupropion and nicotine sprays, but not the other ones, because we have no representatives in Paraguay of these firms that produce them. And well, not all patients want to stop smoking because it's one of the most of the strongest addictions there is. So the first thing we have to do is where the patient, at what stage the patient is. Does he smoke? He or she smoke? What or how much does he smoke? He or she? And we have to be able to provide advice and assist and help these patients, and also with the help of psychiatrists in order to and also provide them, an accompaniment, or we have to follow up and provide them and help them throughout the whole process. We have several alternatives. These alternatives are not a question of only one interview. It's a whole process. We have to inform them about the risks associated to smoking and what would be the results, the best results, also the reward for stopping smoking. And we have to really insist on that during quite a long process normally. In Paraguay, we have worked many years in order to have supporting legislation. When we signed the framework agreement with PAHO in 2006 and in 2015, we achieved the first, we had the first laws and decrees in order to launch a campaign for stopping smoking, and we have gone on. We have achieved 22% positive level of positive results, and the sciences ministry supports us also by establishing smoke-free spaces. We have achieved that also. These were the challenges found in Paraguay. They were quite important. We have a scarcity of the equipment and the factors necessary, the products necessary to stop tobacco consumption. We have also delays in providing medication and the resistance to change by the health teams. We have 18 regions, health regions in the country. 16 regions have specialized centers for spirometry or spirometers. And there is also a problem with the delay in supply of medicine, of medication, of the necessary drugs. And what we also saw was the resistance to change by the health professional teams. Our professionals at world level that usually work with high tension, with established routines, the introduction of a new routine produced anxiety and uncertainty. They were afraid of making mistakes with these new responsibilities. So we had to provide the necessary training in order to reduce this resistance by reducing the possibility of providing also only partial care or incorrect measures. And as you see here, one of these training sessions one of these training versions was implemented through almost the whole country. This training was provided to healthcare providers of all levels. And here you see that the red areas do not have certified trainers. The yellow ones are the ones that have one certified trainers. In green, the areas with two certified trainers, and in blue, the one with three certified trainers. It was also important to train professionals in these guidelines, in setting up these guidelines. Here we have the 20 professionals that work that are a part of our training programs.
Nuestras estrategias locales, creo que ya
The
hablamos
local
de eso,
strategies, I believe you already mentioned
fueron
them,
la capacitación sobre
were
todo
the training
debido a nuestra situación
due to
geopolítica y
our
económica. Muchas veces
geopolitical
puede
and
ser
economic
online.
situation.
Estas
The
capacitaciones
training
online
has
bajo la
has to be
OPS
provided
se
oftentimes
realizan una o dos veces al año a través del
online
Programa
means,
Nacional de Control de
and this
Tabaquismo
is done
y en algunas
once or
oportunidades se
twice a
hacen de
year,
manera
and in
presencial.
some cases it is
Así que,
also in person.
bueno, y hasta aquí nuestra experiencia.
This is our experience and our
Excelente, muchísimas
presentation.
gracias,
Thank you very
doctora
much.
Ayala.
Well, thank you very
Realmente
much, Dr. Ayala.
más de 450
To have
participantes
more than
conectados por más de 90
450
minutos, realmente
participants
habla del
connected
interés
to
y la
this
riqueza que se ha recorrido
session shows that
en este primer
this
webinar,
is
en
a
esta
very
actividad.
important issue, and
Y antes de dar la palabra a nuestros colegas del Departamento de Bioenergía en
become very
Investigación en Perú y
interesting for
concluir,
many of us.
yo invito a los
So
panelistas que quieran tomar la palabra con un último mensaje
before finishing our
para los
session,
participantes
I would
en
like
cuanto
to
a qué elementos realmente
ask the
consideran como consejo
participants
político, ¿no? De
to
implementación y seguimiento de estas herramientas.
well,
Entonces,
we asked
doctora Ayala,
participants to ask the
exactamente, ¿cuál sería
questions.
su consejo para
In
poder
this
reforzar
case,
esta
about the critical advice you would provide.
Para nosotros como sistema de salud, lo más importante fue que al elaborar estas guías nosotros descubrimos de que era mucho más fácil trabajar a nivel país, porque en muchas ocasiones trabajábamos sectorialmente, no teníamos una visión
Oftentimes, we
esquematizada como
worked
de
on
cómo
a
tratar a un paciente en cada
sector by
país. Entonces
sector
teníamos
basis, and we have no
global. Entonces
view, a
nos
global view of
realizamos
how and standardized view of how
Muchísimas
to
gracias.
treat
Doctora
individual
Vieito, ¿tiene
patients.
una reflexión final?
Dr. Vieto, would you have any final thoughts? Yes, perhaps some important issues to be underscored is that we always need highest possible political support to involve all the concerned parties, and additionally, the official recognition of all these documents to make these patient treatment protocols to be adopted, and to finally involve users, members of academia, other stakeholders involved in to prevent any kind of resistance, and to be able to put into practice all the tools that are currently available, like telemedicine,
Perdón,
to
doctor.
facilitate this process.
¿Alguna reflexión final?
Dr. Morrison, would you have any final recommendations? I think it is important to underscore that we must take a comprehensive approach to all these conditions, with a programmatic approach for comprehensive quality improvement, and to create these tools to guide decision making, and giving each the position they support. In other words, countries must have a quality evidence-based guidelines, and then move to the clinical pathways that we feel is the friendliest for health teams. We focus on clinical pathways for cardiovascular disease, but many countries have also adapted these tools for microvascular neuropathic complications in diabetes patients, and they are also using this model for asthma and CPOD conditions, and we feel this is the path to follow, and we are perfectly willing to support our countries with the available resources. And finally, Dr. Ludovic and Dr. Garcia Sensa to conclude this series, and also with an invitation to be attentive to future programs. Ignacio could not
Tal vez de
connect because he's not in the office, but to conclude, I want to say that I totally agree with all the comments from our prior colleagues. This is an opportunity for cooperation among countries because this prevents duplicating efforts. If a country has compiled evidence and made the recommendations, and those efforts can be useful to other countries that can put them in the right context. And to also conclude, on behalf of Sebastián Garcia, who is director of the Intelligence Sciences for Health Actions, and to conclude on this first seminar on better care for non-communicable diseases, I would like to underscore the commitment on leadership of regional countries that are the true engine driving this agenda forward, with specific examples from El Salvador and Paraguay have shown. And also the technical teams of PAHO from the various areas and departments have contributed to this effort, and the cooperation among countries, territories, and technical teams is critical to move forward in improving care for non-communicable diseases. And this seminar, we have paid particular attention to tools, evidence-based tools, with a special attention to guidelines and clinical protocols. This original research brings together over 300 guidelines, protocols, and clinical pathways from 22 countries gathered through 2025, and which we will continue to update on a regular basis. More than a repository, it is a living tool that makes access to evidence based recommendations easier, and provides strategic inputs to policymakers. The innovation of these technical seminars is that they are part of a comprehensive information itinerary. In addition to the over 20 courses that are already provided in Spanish, English, and Portuguese in the virtual campus, we are now adding this certifiable format in both live and asynchronous formats. This means that each session can be followed live or subsequently. And upon completing 5 sessions and the corresponding evaluations, an official certificate will be provided. To this, we add the comprehensive digital solutions that OPS is fostering, and
estos recursos muestran cómo la innovación digital está al servicio de la equidad y la calidad.
These tools are put at the service of the objectives of better healthcare and equity. The cycle, including 5 meetings, will be taking place through December. Each seminar will provide opportunity to delve into key aspects of this initiative, share experiences, and strengthen collective capacities. On my behalf and in my name and on behalf of Sebastián and the whole team, I invite you to continue participating actively in this series, and to keep working in a spirit of cooperation to put into practice the lessons in your specific context. Thanks very much for their commitment and to accompany us in this initial technical webinar. Thanks very much for your time and attention, and have a good afternoon.